Thank you very much, Mr. Chairman, and I'm going to really try to make this short in the interest of time. So if we can have the slides, please. So my task today is to talk about population health, and population health is a major population strategy that is a governmental process aimed to tackle widespread lack of cholesterol control on a very large basis. Now, we have familiarity with population level control when we saw the COVID-19 program that has saved millions of lives worldwide, and it was a top-down approach. So one of the points about the population strategy is we are going to treat the whole population as if it was a patient. It aims to reduce the average exposure of the patient with a common risk factor to shift the entire distribution curve towards lower risk, not the individual patient, the whole population. And instead of concentrating on prevention in the highest risk individuals, we initiate prevention in moderate and high risk individuals as well. And if the whole population can be considered as high risk from a common risk factor perspective, such as hyperlipidemia, then preventive medicine should really target the whole population. Now, bear in mind that most events occur frequently from large numbers of patients in populations considered at low risk of disease because of poor classification, particularly using the risk scores. So the challenge is called the prevention paradox. The prevention paradox implies that you have to deal with the entire population to deal with one single incontrovertible cause of disease, that is high LDL across the board. You dramatically lower the CV burden for the whole population. You shift the risk levels of all of the members of the population, but even slightly, like 1 millimole, can greatly impact the burden of disease. However, because for the individual patient, the small perceived benefit for the individual, especially the younger ones at early stage, means they don't have the motivation to actually participate. LDL, of course, is a silent disease until it strikes suddenly as MACE or sudden death, and not painful. And of course, excessive negative input from social media and vastly exaggerating the risks of lipid-lowering therapy and undermining the huge benefits. So this is the paradox. This is how we have to address it. So this is something very important. You can use this for hypertension. You can use this for dyslipidemia. So if you have a moderately elevated high LDL, is common in the large number of patients in the population. Severe hyperlipidemia like FH is rare in large numbers of the population. Now for the huge number of patients in the middle of the curve, there's going to be a massive population benefit if you address the center of the curve. We're basically talking about patients with an LDL of 120. Why 120? Because that's the LDL at which almost every patient has a myocardial infarction when you look at the ACS registries. Now, of course, for the individual patient, it's urgent if they have FH or severe hyperlipidemia. You have to address this for the individual patient. But the number of these patients is small, and the area under the curve here is tiny. This is where we need to focus, the middle of the curve where almost everybody is. So very early intensive and sustained treatment prevents plaque in the first place. We don't go from the fatty streak to anywhere else. When that happens, you are basically preventing the growth of the plaque. You are preventing the plaque rupture, i.e. there is no role for secondary prevention if you are intensively doing primary prevention in everybody at risk. So going back to the UAE, this is why we need to do this, okay? And I'm sure it's the same in the Kingdom of Saudi Arabia. Number one cause of death of the main NCDs is premature death from cardiovascular disease. The age of MI in UAE is 49 years, 11 years younger than the EU. It's responsible for 19% of all deaths. It's really a very serious problem. And it also is increasing, 30% increase in the last 10 years of ischemic heart disease. Dyslipidemia, number one risk factor for cardiovascular disease, and number one increasing cause of death and morbidity. So the impact of clinical inertia and failure to treat is this. Because the risk of cardiovascular disease is dramatically after 60, most of those primary prevention patients become automatically eligible after 60 because of the use of calculators. However, the number of those aged less than 60 is much greater than the number of those more than 60. So that's the problem. And one of the important points is if you're going to use a risk-based strategy, you have to have an accurate risk calculator, especially in young patients. So because the central criteria is risk, those patients who have a need for earlier intervention are not addressed by Western guidelines or Western calculators. The Western calculators start at 40 years old. Our average patient is 49 when they have their heart attack, so it's ridiculous to use these calculators. In fact, this is not just my opinion. This is a systematic process that was studied in the UAE from a cohort of patients who already had a myocardial infarction. When they took those 2,000 patients and they subjected them to every single risk factor score, score H, pooled risk equation, Framingham, WHO, and ACC, AHA, there was only a 55% concordance in young patients who already had a heart attack. Meaning that this is a huge challenge for any physician or any system. Are these patients really safe based on the calculator? The answer is absolutely not. Half of them are going to be missed. So using the calculator is actually a form of inertia. Why is this? Because in the calculators themselves, young age of events in our population, highly dependent on age, being more than 40 in the risk calculator. So this is why these are dangerous tools to use in our region. Now this is actually an analysis from the NHANES study where they actually included conventional risk, They actually included conventional risk. With conventional risk, that's the big red box that they're already included. 7.5-year risk and going up will be included for therapy anyway. But what about those patients here who would have a benefit? These are patients on the left. If you look at the potential benefit of lipid-lowering therapy, it's a much denser group and they have a greater absolute treatment, not dependent on the cardiovascular risk score. We're missing the patients between 5 and 7.5. That's most of the patients sitting right there. Now, this is a complex and busy slide just to show you that if you do not use age-dependent criteria, but you simply look at the benefit of therapy, the number needed to treat by using a high-intensity statin and not depending on the age goes up 8.7% event reduction because of the use of lifetime risk instead of a single number of age-dependent risk. So I think this is key. Now, in the region, you know this is the DYSIS-2 study. 90% of the patients after an ACS do not achieve LDL targets. In addition, this was also shown, 0.9% of our population in the Gulf have familial hyperlipidemia. So they already have a high burden of atherosclerosis. Now, when we looked at our own internal data, this is one of the very large diabetes centers, very closely monitored patients. They come every 3 months, 42,000 diabetic patients, 31% high risk, 10% with heart disease or high CV risk. What percentage at target? There it is. 71% of patients not at target with a mean LDL of 3.1. All of these patients are on statin, i.e. we're not intensifying, we're not recognizing, we're leaving the majority of our patients to have events. Now, we know that this is a linear relationship. LDL is no longer a theory, it's a fact, it is incontrovertible, it needs to be reduced. If you don't reduce it by whatever means, regardless of the therapy, you are going to do this. You are going to increase cardiovascular risk. Failure to lower increases cardiovascular risk. The guidelines are very clear. There's 2 numbers now, 1.4, 1.8, and 1.0. So because of the massive burden of uncontrolled hyperlipidemia in the UAE, the status was recognized as an urgent public health issue, very large magnitude, lethal implications, and there was a decision taken after a lot of deliberation to do a wide-scale population health implementation. So the objective of this implementation is here, to save about 14,000 lives within the next 5 years by implementing the WHO best buys, particularly the easiest one is LDL lowering. So how are we going to achieve this? Now, you've seen this is the Da Vinci study. And in fact, in the most of the patients who had an MI, right here in red, had an LDL of only 2.4. If we reduce this 1 millimole per deciliter to 1.4, it's going to result in a 10% change in the risk over 15% of the population. That's literally talking about thousands of patients getting protection with a 1 millimole reduction. Now, how are we going to do this? How? Traditional approaches have failed, inertia has failed, patients are dying. So one of the key components of the Abu Dhabi Public Health Program is a large ability to find patients easily. How do they do that? Because they have a national electronic medical record that allows real-time patient identification of risk, LDL, and whatever treatment they're on at the patient level for the whole population. Every facility and every provider has to be part of the system. It's been part of the system for 5 years. So the challenge is still fragmentation, insurers, hospitals, guidelines, different lab values. So the government has to take over and do LDL control on behalf of the population, just like COVID-19. There are many different elements of this. Without going into the detail, the key component highlighted in red is the national EMR database owned by the government. And it allows you to aggregate the data, to find the patients,
to cause care coordination, and also to report your results through analytics, because then you can see the LDL response after your treatment initiation. So this is one of the things that happened, and this is the signatory of the of the agreement. And I think this is something that's very forward-thinking. Now, on the DOH website, you can actually see this very important statistic. The aim is to treat more than 74,000 patients, all of whom have been on high-intensity statins and are considered high risk. About 6,000 lives will be saved, half of whom are expats and half are UAE nationals, 12,000 non-fatal MACE events, and 92%, i.e. an 8-fold increase in patients achieving lipid-lowering targets. This is part of the working group. It took a long time for this to happen. It was almost 1.5 years of work, multiple different groups, continuity of care, data, national lipid pathway, education, and funding. This program has to be funded centrally in order for it to be successful. Exactly the same model as COVID-19. So all of this is basically part of the pathway. It's fairly straightforward. You start with your risk. You start with your higher intensity statin and ezetimibe. And particularly, the DOH has recommended the use of inclisiran twice yearly as a vaccine-like approach, because you can scale it up almost infinitely with very little resources, and you can guarantee the compliance. So in terms of investment, I think this is a very important model that the WHO has come up with for long-term treatment. If you invest less in prevention, you will ultimately have to treat and deal with more illness and more hospital treatment. If you go up front and deal more with prevention early, then illness is reduced, treatment is reduced, intensity is reduced, and hospital costs are significantly impacted. The World Heart Federation roadmap actually is a unique document that I think is really guiding towards very large population management. Many different elements, including the awareness of the risk, population-based management, reinforcing the risk assessment, and implementing system-level approaches. This is not for the individual physician. This is the whole nation has to be part of this issue. So in reality, if you think about how, and this is from the Brunwald presentation at the ESC and also his very famous paper, if you take a single injection at the age of 30 every year, and you never reach the threshold for LDL causing atherosclerosis, then you have essentially eliminated the likelihood of atherosclerosis in the entire population. And this is quite controversial, but I think that's the idea that's being proposed when you talk about population health. You never reach the threshold of ASCVD by simply not having enough LDL in the system. So that WHO paper has a very similar concept. If you start the patients later in life, at the age of 60, with lipid-lowering therapy, reducing their LDL by 50%, yes, you will get a lifetime reduction of 25% events. What if you do it early? What if you start lipid-lowering therapy with a 50% reduction at the age of 30? Look at this, 52%, almost doubles the lifetime survival of the patient simply by starting early rather than late. Now, the other side of the coin is this. What happens if you start earlier? So this is another model which uses the same concept. You take a 33% reduction, a moderately intense statin, at the age of 40, compared to a 50% reduction starting at 55. Earlier always wins. You never form atherosclerosis. And by doing that, the proportion of cost to treating ASCVD declines, and the proportion of cost preventing increases, but overall, the overall cost decreases significantly because you have less events and less hospitalization. So that's really the single fundamental point of this model. Now, the previous speaker talked to us a little bit about the adherence, and I think long-term adherence with these therapies, particularly applied to the whole population, is essential. So when we looked at the Euro Heart Prevention Study, 2 million patients, about 130,000 cardiovascular events, the main risk factor here was non-adherence and not taking all of the lipid lowering and other therapies. So with that, 9% of CV events in Europe could have been attributed or prevented by completing adherence. And this is from the group in Glasgow. If you look at this very clearly, if you use low intensity and non-adherence, your likelihood of response or reducing events is very low. If you're high intensity and high adherence, you're going to have a massive change in your LDL, which of course translates into cardiovascular benefit. Now, why did the DOH specifically think about inclisiran in the population health model? Because of the scalability. So this is actually from the UK. This is the NHS model. This is not the UAE model, but it's very similar in the idea. Because the implementation is a pathway that is being done by general practitioners for a large number of patients, the second group is implementation and looking at the LDL control and the targets. How many patients do we really achieve the LDL that is going to reduce the cardiovascular events. So come back to this point here. So Braunwald made this statement, and it's a very important one. You take a 30-year-old gentleman with an LDL of 100 at the age of 30, once a year injection with the flu vaccine, a 40% LDL over 40 years will lead you to that reduction of the threshold. You never actually have the events. Similarly, if you take the same concept and you take a high intensity plus great adherence by having only 2 patient contacts per year, then you're going to get a reduction of the hazard ratio by about 40% over 5 years. So you accrue benefits early and late. If you have a low intensity and non-adherence, again, you're only going to reduce your risk by about 10%. So it's a combination of both intensity that's driven by PCSK9 therapies in general and adherence that's baked into the twice-a-year injection process. So we know from the Orion study that 87% of patients achieved an LDL of less than 70. 50% reduction is the norm with this therapy. And the long-term extension of the Orion study is basically here. As you see, there is essentially a 50% sustained reduction with 9 injections after 4 years. So what we're talking about here is a prolonged sustained reduction you can apply to large numbers of the population. Now, the other important point is this: by solving both the intensity component and the adherence, in the Orion pooled data, there was a 25% reduction in MACE. So the LDL was reduced by 1.37 at day 90 and 1.38 at day 540 with the 4 injections. This resulted in a reduction of pooled MACE collected as adverse events, not adjudicated, but actual MACE, as 25%. So as we totally predicted from the CTTC curve, 1.4 leads to 25%, 1.0 leads to 20%. It's completely predictable and very straightforward. Now, one really important point is this. This is from the Fourier open label extension. This is something to be very proud of. In reality, PCSK9 monoclonal antibodies have done something remarkable in the science, because we have seen now, after 5 to 8 years of exposure to the monoclonal antibody, evolocumab, we got every single patient to a median LDL of 0.75. 0.75. What did that account for? A 23% reduction in hard endpoint of cardiovascular death. So this is phenomenal. We have now shown that cardiovascular death can be reduced compared to other therapies using a very potent PCSK9 inhibitor. However, it requires 100% adherence with the injection and the background therapy with the statin. That's 130 injections over 5 years if you're 100% adherence. Now imagine if you had 10 injections of the RNA inhibition plus the statins, 5 years, no injection missed. That's the key point. We believe that LDL is the direct precursor of atherosclerosis, and now here we have a long-term tool that avoids the patient's compliance being an issue. So this is an issue also of variability. I think we've talked about this indirectly. So this is an example of one of our patients. After the first, second, third, and fourth dose of, as you see exactly in the clinical studies, you have a flat curve. LDL is 0.25 over the course of a year and a half. Now you have this problem of variability in conventional lipid-lowering therapy. This is a typical patient on statin and ezetimibe. They start with an LDL of 2.3. You bring them down to 1.8 by adding ezetimibe. But if you look at the number here, 73 out of 76 readings over 10 years are above target. That's not controlled, that's just average. And only 2 readings are below 1.0. This is the point. You can eliminate the variability or compliance, or whatever issue causes this, by giving the patient a therapy that flattens the curve completely and does not depend on the patient taking the injection or not taking the injection. It simply lowers the LDL through production issues. Now, one of the points that was made by Braunwald's speech, and I found this very interesting, this is one of our real patients. He had the first dose but missed the booster dose. 7 months later, the LDL is still 80% lower at 0.82. So I think this is telling us that the utilization of therapies that last longer deal with the non-compliant patient and reduce their risk no matter how badly they behave. So, final points here about the population health program in Abu Dhabi. There's a pilot phase, which is the diabetics and secondary prevention, primary prevention, and national comprehensive program. I've had the privilege of being part of the pilot project in the UAE, and this is the publication. We actually presented this at the British Endocrine Society last November. In reality, we found these patients, 146 patients, the mean LDL starting with 3.7, post-LDL with inclisiran 1.78. 50% of patients or more, actually 62%, achieved a target LDL of more than 90% reduction. And we see here the target population in the UAE now has been expanded beyond the model in the UK to include very high-risk diabetics, that is patients with diabetes and target organ damage or multiple risk factors, plus diabetics with a single risk factor or long duration. In addition, we are recommending the use of risk enhancers. Every patient has to have an annual check on risk enhancers, including family history, primary hyperlipidemia or triglyceridemia, metabolic syndrome, CRP, ankle brachial index, and GFR. So these are the patients with atherosclerosis. They're also included in the program. And in addition, we have patients with familial hyperlipidemia and high CVD risk due to renal discomfort. So finally, last word, cost. Very important that we spend about 2/3 of the healthcare expenditure on 5 to 10% of the patients who end up in the hospital. And of course, this is the analysis that the Department of Health did before making this decision. They realized that in 4 different and highly cost-effective clinical interventions, including diabetes and hyperlipidemia, 32,000 deaths, 20 billion dirhams of economic loss would be averted by 2034 if we directly attack the LDL, at least in a population health manner. And thank you very much for your time.